Welcome to those that have joined us already to this second in series of 3 ARC seminars on health inequalities. A very warm welcome to all of you. We've had an overwhelming response to this seminar today. We're really delighted with the numbers that have expressed an interest in this talk, in this very important area. So today is going to be a really good seminar. I can just sense it. So again, a very, very warm welcome from me. I'm Professor Marion Walker. I'm an Emeritus Professor in Stroke Rehabilitation at the University of Nottingham. But most importantly for today, I'm ARC East Midlands Collaboration Lead, and I also chair the Equality, Diversity and Inclusion Committee there as well. So this seminar is being hosted by ARC East Midlands today, and it's an absolute pleasure because health inequalities are at the core of everything that we do within ARC East Midlands. And from the variety of presentations across all the ARCs, it's very clear that this is a really important area. We have a very exciting list of speakers today. We have 3 talks from 3 different ARCs. The first talk will be from Dr. Jolie Keemink, who is going from ARC Kent, Surrey and Sussex, and she will speak on inclusive residential care for LGBTQ plus elders. And for all speakers, we will have a 10-minute presentation plus 5 minutes for question and answers. And at this point, I just want to say that please put your questions as the talk is going on into the Q&A section. The success of these seminars is based on the other questions that people want to ask, because there's a lot of learning in the question and answering session. The second speaker today is Dr. Sabrina Bajwah, who is going to speak on understanding palliative care needs of ethnically diverse patients. And the third speaker will be from the Northwest Coast ARC, and it'll be Dr. Clarissa Giebel on inequalities in dementia. What are they and what can we do about them? So it's a very great pleasure for me to chair this meeting today. And I will hopefully, I will make sure that everybody gets the opportunity to ask questions. I also just want to highlight that our Twitter handle is at NIHR ARCs, and we will be tweeting using the hashtag ARC seminar. So please tweet as we go along today. It's important that we share the word and share the interesting topics as we go along. So yes, I think just again, please put the questions in the chat. I'll be monitoring those, and please tweet as we go along. So I'm going to invite the first speaker, who is Dr. Jolie Keemink. And I'll just tell you a little bit about her before we start. Dr. Keemink is from the University of Kent Centre for Health Services Studies. She has extensive experience in quantitative and qualitative research methods and has worked extensively with minoritized groups across the age spectrum, from infants to care home residents. She leads the Circle project, creating inclusive residential care for LGBTQ plus elders, and she's funded by ARC Kent, Sussex and Surrey. And this aims to support residential care providers for older people to be more inclusive for the LGBTQ population. And today she'll be talking about the Circle project. So welcome everybody, and over to Dr. Keemink.
Thank you very much, Marion. So thank you very much for the introduction. Yeah, as Marion said, I'll speak today about creating inclusive residential care for LGBTQ plus elders. I just wanted to add my pronouns are she, her, and I'll try to keep it brief because 10 minutes will fly by, but I'm going to try and cover as much as I can within the 10 minutes. So I just wanted to give a little bit of background around health inequalities, care inequalities that LGBTQ plus older people face. Older LGBTQ plus people, and LGBTQ plus stands for lesbian, gay, bisexual, trans, queer, questioning, and other marginalized sexual orientations and gender identities. Older LGBTQ plus people experience verbal and physical abuse in care environments. Not everyone will experience this, but they experience this more than heterosexual and cisgendered people. And of course, this shouldn't be happening at all. Minority stress, so the stress of being part of a minority group, raises the risk of older LGBTQ plus people of needing social care. So over their lives, they accumulate trauma and stress because of their minority status, which raises the risk of them needing social care. And this also sort of means that they get stuck in a bit of a loop because the minority stress raises their risk for needing care. And then in care, they experience homophobia, biphobia, transphobia, which then increases the risk of poorer outcomes and requires them to need more care, which is really unfortunate. But it's also good to emphasize that a lot of older LGBTQ plus people are very resilient and have built their own safe groups and networks around them. Nevertheless, older LGBTQ plus people experience higher levels of loneliness and social isolation compared to their heterosexual and cisgendered counterparts. They're, for example, less likely to have a good social network. They sometimes have broken with their biological family, are less likely to have children. And older LGBTQ plus people indicate that they feel like they have to go back into the closet to be safe in care environments and to hide who they really are. At the same time, care services are predominantly heteronormative, which means that they approach the world through a heterosexual lens and assuming that people who they encounter are heterosexual, and cisnormative, assuming that people are their gender corresponds with the sex that they were assigned at birth. And they do not always see the relevance in LGBTQ plus status for care needs. So I often hear care services say that they treat everyone the same, but by saying that, you sort of emphasize that heteronormative lens and you disregard the importance of the additional risk factors people may have, but also what it means to their life to be LGBTQ plus and maybe the stress and trauma they've lived through in their life. Care services also often disregard LGBTQ plus relationships or do not treat them the same as heterosexual relationships, with, for example, people not being involved in their partner's care. And there's also a lack of consistent training on how and why to provide LGBTQ plus inclusive care. That's a bit of a background. So if we speak about LGBTQ plus inclusive care, what do we mean? So that is access to care and resources that is equal and equitable to cisgender and heterosexual people. It's an environment in which people's differences in sexual orientation and gender identity are not just tolerated, but valued and celebrated. It's an environment where sexual orientation and gender identity are seen as relevant to care needs. What I just mentioned, that doesn't happen enough right now. It's also a place where full participation in the care environment is facilitated, and then you can think about really big things, but also about really small things like the entertainment that you offer and the holidays that you celebrate. It's also care where discrimination and intolerance towards LGBTQ plus people are addressed and eradicated. And it's really important to emphasize that a lot of LGBTQ plus people who are in older age now have lived through decades of discriminating policies and laws, which has really affected their trust in public services. And it's also important to emphasize that there are people who have intersecting identities, so do not only identify with the minority status of being LGBTQ+, but for example, also being disabled or part of a minority ethnic group, which can then increase their experience of discrimination. The study that I'm leading is called CIRCLE, creating inclusive residential care for LGBTQ+ elders. The study is almost coming to an end this September, and it really focuses on how residential care providers, so care homes, can be best supported to provide inclusive care. So we know that people do not always receive inclusive care. We know that the care workforce feels unequipped to provide that inclusive care. Often, in my experience, the willingness is there, but people do not always feel confident or skilled enough. So we wanted to look at how can they best be supported to provide that inclusive care. And we're exploring and evaluating 3 different ways of that support. One of those is a comprehensive inclusion program that assesses different elements of a care home organization. And it doesn't just look at staff, but it looks at policies, it looks at marketing materials. It also looks at staff attitudes, it provides training. So we're trying to take a really holistic approach to embedding inclusion within a care home organization. And the evaluation looks at, does this program work well in a care home setting? Thinking about all the pressures they're already under, does it work well? Is it well implemented? But also, does it have an impact on the skills and confidence of the people working in the care home? I'll be quick. We also have an online community of practice. That's a group of people that meet quarterly to talk about an aspect of LGBTQ+ inclusion, and we measure the impact of that community. And we have also designed a resource for care homes together with older LGBTQ+ people and care home managers that they can use in practice to improve their LGBTQ+ inclusion. In the interest of time, I'll just skip to this one. So the community of practice meets quarterly, and it's meant to be a very low threshold, accessible way of learning more about LGBTQ+ inclusion. It's a safe space. People can come and join online. It can be interactive, but you can also just listen if you don't feel confident enough to be interactive. And we talk about a different aspect of LGBTQ+ inclusion each time. And some of the data we've collected around the impact is shown on this slide. So people have said, it's furthering my knowledge on a subject mostly unknown about within my organization. These conversations are vital for supporting older people who are LGBTQ+. Attending these events has strengthened our support of services we work with, and networking and hearing live stories, feeling validated. So you can see that they really have a positive impact on increasing people's confidence and knowledge in this area. We've also co-designed this resource that was with a group of 8 people for older LGBTQ+ people for care home managers. We've created a Z card, which is a card that you can see in the top right corner that folds into a very small sort of credit card size card, but you can then fold it out into a map size where we provide all sorts of practical tips on the do's and don'ts for LGBTQ+ inclusive care. It's very practically focused. Not very text heavy. It's really focused on things that you can do that are free, that are mostly just behavioral things that can make a big difference for LGBTQ+ people and how included they feel. There's also a complimentary video for people who prefer to take in contact through audio. And we have a logo that people can download to indicate that they're committed to improving their LGBTQ+ inclusive care offer. We're launching this resource on the 11th of September. There's a QR code here for the launch event, but I might also be able to post that in the chat later. And here's a little sneak peek of the resource. So on one side, we have an image of people in front of an inclusive care home. And the quotes there are from LGBTQ+ people who worked on this project. So one of them, for example, says, when care is LGBTQ+ inclusive, I can physically relax, I feel safe, and I can blossom. And we also have to the right, you can see a little sneak peek about the tips that we have included on this set card. And it will be free to download, but we also have physical copies, and it will be launched on the 11th of September. Oh, someone has already posted that in the chat, which is fantastic. And then I'll just end quickly with some early practice recommendations. If you work in care and you want to think about more about LGBTQ+ inclusive care, think about building relationships with local LGBTQ+ organizations. I'm just going to pick a few out because I know the time's passed really quickly. Open the conversation. People find this topic really awkward to talk about, sexuality and gender in older age, but it's really important to not avoid it. Make sure that you collect data on sexuality and gender identity, because otherwise you can't monitor inclusion. Be specific about your commitment to LGBTQ plus inclusion, and make sure that you provide consistent lived experience-led training to staff on LGBTQ plus inclusion. This is my team, and thank you very much for listening. I'm very happy to answer any questions or receive emails if people want to talk further about this topic. Sorry about the rush.
No, thank you so much, Jolie. That was great presentation in a really important area that I'm sure is greatly under-researched at this point in time. We've got some questions in the chat, and during your time, I think I'll just take some of them.
Yep.
The first one is, do the LGBTQ plus community experience such prejudice predominantly from staff or fellow residents?
It's both, really. I think there are definitely too many stories of people experiencing discrimination from staff. There was a case discussed in a Westminster Hall debate last September of severe physical abuse. But definitely people also mention other residents, and I think that is often trickier to address, especially if you're dealing with people who have cognitive impairments, for example. But I think it's really important that staff still have a sort of no tolerance policy on discrimination, even if it comes from other residents, and that they have a clear policy and structure to follow, and also a place where that can be reported, because that often is lacking.
Yeah, absolutely. Second question, has your research uncovered any instances of an individual identifying as a particular gender and therefore wishing to participate in an activity that is targeted at this gender, but because this gender is not their biological sex, it's raised difficulties? I'll just ask the first.
Yeah. I think this is definitely something that happens. I'm not sure if it's just referring to, for example, activities of enjoyment. So I've heard stories, for example, of where they had activities around weddings, and it really was very heterosexually focused. But for gender, you can think more about things like going to a nail salon or hair salon, and people are only assuming that people who present as what people would traditionally see as a woman to be invited to something like that. But you also have to think more about, when we talk about health inequalities, things like screening for certain types of cancer that may be related to female or male biology, and that people are being excluded because of how they present and not necessarily their biological gender. So absolutely that happens, and I think more awareness needs to be raised around that.
Thank you. Next question, has the closure of Opening Doors London affected your research?
Absolutely. The program I mentioned was initially their Pride in Care program that we worked with. And because of that closure, we've had to sort of now rename it, and we're still including similar activities. But I was collaborating with Opening Doors, and they were a very valuable partner, and it's very sad that they've had to close. Yeah.
I think what we'll do is we'll stop there.
Yep, I'll try and answer some of the questions by typing. And
Jolie, if we don't get to answer these, people can contact you afterwards for their questions.
Yep.
But we've got some space.
Yep.
At the end, I'll pick up some more as we go along.
Thank you. Thank you very much.
Okay, so thank you. And we're now on to our second speaker of this session, Dr. Sabrina Bajwah. Sabrina is a clinical senior lecturer in the Department of Palliative Care Policy and Rehab at King's College London. She's an honorary palliative care consultant at King's College Hospital. She's chief investigator on a Medical Research Foundation funded study developing an educational film to improve delivery of equitable end-of-life care. Her research interests include different models of palliative care and racial inequality. And it's a very great pleasure to hear your talk today, Sabrina. So over to you.
Thank you. Thank you for the introduction and for inviting me to speak today. So I am a palliative care consultant working at King's College Hospital in South London, an incredibly diverse population that I serve. So we're more than 50% non-white British, so predominantly Black African, Black Caribbean community. And I want to really present some research that we did during COVID around racial inequality and the work that we've done related since then. So next slide, please. So our research was the COVPAL research, so the NIHR ARC South London supported study looking at the palliative care response during the COVID pandemic. And in particular, I led the area looking at the palliative care response for ethnically diverse patients and families during that time. So the aim of the research that we did was to map and develop insights into the response of specialist palliative care services caring for patients and families from ethnically diverse groups during the first wave of the COVID-19 pandemic. And what we did is we conducted a cross-sectional online survey of all the UK palliative care services, and we collected both quantitative and qualitative data. Next slide, please. So in the survey, we asked three main questions. We asked services, have you encountered patients or families with COVID-19 who are from Black and minority ethnic groups? And then we asked open-ended questions. Are there any differences in how you are supporting or reaching them? And are there any groups, different religions or cultures where you have found supporting the individual needs of these people affected by COVID-19 particularly challenging? Next slide, please. But first to speak to our quantitative results. So we had 277 services reply from across the UK, and that was a fantastic response to our survey. So importantly, 93 out of those 277 services had cared for ethnically diverse patients. And of those, they were predominantly hospital teams. So 49% of those caring for ethnically diverse patients were hospital palliative care teams. And that is reflected in the results on the bottom left as well. And those are interesting results because during the COVID pandemic, that actually are inpatient hospice teams reported being much busier, but actually it was the hospital teams that were mostly seeing these ethnically diverse patients. The qualitative results are incredibly interesting. So there were 5 main themes that came across in the qualitative results. So when discussing the impact of restricted visiting, so if you cast your mind back that there was restricted visiting in hospitals for patients and all settings such as hospices at the end of life. So patients were dying alone. But what was actually reported by the palliative care services is actually the impact on those from ethnically diverse patients and families seemed to be disproportionate. And one of the things which comes out in theme 1 and theme 3 is really actually there was that disproportionate impact appears to be related to the fact that often in different faiths and different cultures that it is normal to have many people around your bedside and often praying. And for example, in the Muslim culture, that Muslim religion, that it is normal to have lots of people praying for you as you die, and that transition. And so when that couldn't occur, that impacted those communities more. In addition, there was an impact in terms of communication challenges. So those from ethnically diverse groups lost their translators. So normally you might have a family member present who might translate for you, but they weren't allowed to visit. And in addition, face-to-face translation was stopped. So actually there was very little translation happening for these patients, and this impacted the ethnically diverse groups a lot. In addition, there was also mistrust of services. So where before the services had actually gained trust, that this trust seemed to have been lost, and communities were closing the doors on services. In addition, there was a really interesting qualitative finding that services felt that they treated everybody equally, and that was a fair thing to have done. And there was a lack of a focus on delivering equitable care and recognising that some cultures or ethnicities perhaps required increased care delivery or different care delivery to meet the needs and achieve the same outcomes. Next slide, please. So we published a paper, and in that paper we talk about what are actually the things that we need for high quality palliative care and outcomes. So really importantly, within this paper, we talk about how we should be focused on delivering equitable rather than equal care. And we discuss what we need to do to deliver that high quality palliative care and equitable response. So on the left, if you look at how we have shown that if you're delivering equal personalised care and you have an equal allocation of resources, but you don't respond to individual cultural and religious needs, this leads to disproportionate impact and stress. But actually, to deliver an equitable response and high quality palliative care for all, what we need to do is actually adopt centering on the margins. So to date, I think palliative and end-of-life care has been developed and focused on the needs of the dominant culture within our society, so the white British group. But actually, we need to do more of centering on the margins, thinking about those who are marginalised and what their needs are. And to really do that, in our everyday practice, we need to have meaningful impact assessments of policies and really mitigate against any policy that we bring in which impacts one group more than the other. And the visitation policy during the COVID pandemic would be an example of that. So another building block is including those people who you are developing a service for and making sure that they co-develop services for you. There are limited resources in palliative and end-of-life care, and still the majority of hospices are primarily funded by charitable care, but actually the distribution of resources to the different communities within those hospices isn't equitable, and I think that actually a fairer redistribution of resources is needed. The other thing that did come out of our this survey is there was a tendency to have a deficit placed on the communities that palliative care services weren't reaching. For example, say blaming those communities, that saying they aren't opening the doors, they don't let us in, they don't trust us, and there was a lack of reflection on what palliative care services were doing. And an example might be only having your resources available in English, or only having staff who are white British. So it's really about changing the thinking of where the deficit lies, and that is a fundamental part of culturally congruent care. Next slide, please. So the paper that we have published is in BMJ Supportive and Palliative Care, and it's on the left with the QR code there. So I'm delighted to say that the paper's actually been downloaded over 15,000 times, and this research has actually been disseminated into policy. It was quoted in both UK government equality and human rights policy, and also, I'm delighted to say, in World Health Organization transforming the health and social equity landscape policy as well. So that's been absolutely fantastic. But actually, what really bothered me about this is how do we change practice on the ground? How do we get services to, and individuals working in services, to change the practice that they're delivering? Next slide, please. So this is why I applied for the Medical Research Foundation grant, which was a grant to help disseminate research into practice. So this allowed me to develop a film, an educational film, which is available on YouTube. So this film, Palliative Care, Shifting the Focus from Equality to Equity, is a film which is aimed at all health professionals working in palliative and end-of-life care. And it's what it does is it aims to explain the difference between equality and equity. I think there's just another bit to this slide if you just move it on slightly. Oh no, okay, it hasn't come up. So if we go back, so we do that through an animation. So we have an animation where we are actually showing two people looking over a fence and trying to see a football match. And we explain within that animation the difference between equality and equity. In addition, within that film, we use voices and stories from stakeholders, from ethnically diverse stakeholders, as shown here, to really illustrate the importance of changing things as an individual and as an organisation. And we give 6 ways as an individual and as an organisation that you can do that, and they are focused on the building blocks that I put within that table and in the paper. So I'm delighted to say that this 26-minute film was launched on YouTube last year, and the full film has now been viewed over 4,000 times, and it is freely available for anybody who wishes to view and download. Next slide, please. And also we have developed a e-ELCA learning as well. So this is available for all health professionals and social care professionals, and please do access this as well. So it has the film and then 8 assessment questions. Thank you.
Thank you, Sabrina. I think we're going to have to wrap up there, because just leave a little minute or two for some questions. But congratulations on your paper and the fantastic impact that it's had, and the outstanding number of downloads that it's produced. So just making sure that we give everybody a chance to ask some questions. There's one here. I recognise and appreciate these, especially, oh, it's just jumped from my screen there. I recognise and appreciate the especially adverse impact the pandemic had on those of particular culture, faith, but imagine that it would have been extremely problematic to disregard the rules in place for individuals for these communities, while people not from those communities had to adhere to them. Have you been able to work with these groups to develop alternative pathways? Yeah.
Yeah, so I'm not in the least bit saying that there should have been exceptions made. Obviously, it was a global pandemic, and these strict rules should have been brought in. But I think it's an example, really, of how we do sometimes bring in rules and changes of policies, and we don't think about the impact on those communities on the margins. And it's really to urge people to, whenever a policy or a change in practice is going to be made, that actually thinking about those people on the margins and thinking on who you're leaving behind, and especially in research as well.
And that really underlines the importance of equality impact assessments in all policies that you've highlighted.
Yeah.
So more questions coming in. Have you found the term end of life, or speaking about death, end of life, is difficult for ethnically diverse people?
Yeah, I think it is. I think there was a YouGov poll recently which actually highlighted that issue. I think that there are, I mean, I know I would describe myself as a British Pakistani Muslim, and actually when you intertwine culture and religion, I think that there is a complexity there that isn't, which is very different to perhaps the white British population. And that's why I don't think that we should ever take the white British model of palliative and end of life care and try to superimpose it on other cultures, religions within the UK. And we should do research to assess the palliative care needs. And part of that is looking at culture and religion at the end of life, and what is needed for every community.
Fabulous. And last question here, where do you think cultural competence and implicit bias training fits with the strategy plan?
So if you watch the film, it's very interesting, because within the film, they one of the very eloquent speakers talk about how cultural and religious training used to be something that was routine all the time for everybody, and it stopped. But actually, I mean, what I find really shocking is that I work at King's College Hospital, and at induction you will have fire safety training and various other things. But even with more than 50% ethnically diverse population, we do not at induction or any point during any of our time as health professionals in the hospital learn about the culture or religion of our local community. And I think that should be mandatory, and I can't stress how important I think it would be. I think it would improve communication. I think it would reduce complaints, and I think it would just build trust. And those are the sort of things that, you know, when I say that we talk about deficit and where the deficit is placed, actually that's us as health professionals should own that deficit.
Absolutely. And such an important area that is being explored by ARCs. That's wonderful. We'll have to stop there and move on to our last speaker. But as you can see, there's lots of questions, lots of interest coming in. So please do look at these and try and answer any in the text, or people can follow them up.
Yeah, thank you.
Just to add, at this point in time, we will be sharing all the slides. We will be sharing the videos after the seminar is finished. So please beware that will be the case. So we're on to the last speaker of the session, who's Dr. Clarissa Giebel. Clarissa is a senior research fellow in the Institute of Population Health at the University of Liverpool, an older adult sub-theme lead of NIHR ARC Northwest Coast. She's leading the Institute's Dementia Research Group and is an NIHR School for Social Care Leadership Fellow. And you also host the Aging Scientist podcast, Clarissa. and has jointly launched with your group the co-produced and launched the Dementia Inequalities Game. You've published over 110 papers, including 2 policy briefings in the field, and the title of your talk will be Inequalities in Dementia. What are they and what can we do about them? Thank you. Over to you, Clarissa.
Thank you so much for this lengthy introduction. I think you picked that up from my university webpage, so thank you. Thank you so much. And thank you to the NIHR ARCs for inviting me. Absolute pleasure and honor to be here across those topics. So I want to focus on inequalities in dementia, which is what our research group is looking at the University of Liverpool and within the ARC North West Coast. But specifically, I want to focus on how we can use and work with public involvement and engagement to find solutions to those inequalities and inequities. So I only have about 10 minutes, so it's a whistle-stop tour. What are inequalities or inequities in dementia? Now, this is a selection of the many barriers that people living with dementia and their unpaid carers can face when trying to access a diagnosis in the first place, or when trying to access care after a diagnosis. Now, I am also leading a European task force on inequalities in dementia as part of INTERDEM. And for us, it's really interesting to understand that a lot of these barriers are the same in Poland, in the UK, in Germany, in the Netherlands. But what we also learn by working collaboratively across Europe is that there are some solutions in place in specific countries, for example, the Netherlands, which we are actively trying to implement in the UK. So these barriers can include if someone is having symptoms below the age of 65, so they would be classed as young onset dementia. It's often not recognized within the workforce, and they also struggle accessing suitable care services. They may not wish to go to services that are predominantly targeted at people in their 80s, for example. It's a postcode lottery. You can live in one street and get access to fabulous care. You can live in another street with a different postcode, and the area of coverage is different for your support. Obviously, your financial, your educational background plays a role. And if you have a rarer subtype of dementia, so for example, Lewy body dementia or frontotemporal dementia, all these factors can affect your diagnosis outcome and your care outcome. So now I will present to you very briefly, and apologies for the quick tour through them, 3 approaches we have been developing and implementing within the ARC North West Coast to raise awareness about dementia, raise capacity about dementia, but also, I suppose, to get more people involved, but also go around the very lengthy from research to implementation, which can last years and years and years. It is not always about running a randomized control trial as an intervention to tackle solutions. It can be involving with your local and regional communities. So the first thing was in 2019, I established the Liverpool Dementia and Aging Research Forum, which is a community of practice, as we call it, that brings together different stakeholders across the topics of dementia and aging. It started very small, about 40 people attended in 2019, and it has snowballed since then. So what do? We offer different types of events that are both in-person and remote. We have webinars where we invite different speakers. We have regional networking events twice a year where we'll have little refreshments, etc. And we have care providers and lived experts speaking. We do not want to have all the academics speaking all the time. We want to give everyone a voice. For example, last time at the networking event, we had Merseyside Police talking about what's it like to try and find missing people with dementia. as an example, we also had Belong Care Home Villages talking about their intergenerational work in the dementia field. And we've now done 2 evaluations of this forum, and it's already shown it improves knowledge, it empowers people that normally wouldn't speak up, some unpaid carers, to approach clinicians, to approach academics, and to go outside of the forum to their networks and organizations and share what they've learned. And critically, we found that some people with dementia and unpaid carers were able to access care as a result of attending the forum, because they learned about, for example, Admiral nurses, dementia care navigators. So this can help in a small way, but in some way, to reduce inequalities by raising knowledge and awareness. Now, over to the second one, because this was developed from the forum. So within the forum, we host regular get-togethers with unpaid carers, people living with dementia, health and social care professionals, on different topics. And sometimes ideas develop from the ground up and get repeatedly mentioned in those events. And one of these things that emerged was that training for the health and social care workforce, or even the general population, can be quite dull sometimes if you just listen to talks or you get information leaflets. And the thought was, in a small group of us, we thought, why don't we develop a game, a board game? Because all these academic publications for us, they're really meaningful for us academics, but how can we get the word out there, the message out there, even better than just blogs or webinars, which are really important, but we want to reach people in a very engaging way. So we were lucky to receive some funding from the Wellcome Trust to host 4 co-production workshops, remote and some in person, with different people with dementia, caregivers, care professionals, third sector organizations, and a few academics as well. It was a series of workshops, and you can read about it, because I don't have time to outline the methodology, but what I want to say with that is we all really enjoyed the chatter that emerged in those workshops by people feeling comfortable to share their own experiences of inequalities and adding to the evidence base that we showed them. So we worked together with the Lewy Body Society and SURF. The Lewy Body Society is a national charity to support people with Lewy body dementia and their families. And here you see an image of unpaid carers and people with dementia, where we launched the game on the 1st of September last year at the beginning of World Alzheimer's Month. And what the game does, you can see here the game, it's an old school board game. And we purposefully chose to have a board game, not anything digital, because we want people to socialize and come together. And if they feel comfortable, to share their experiences. So how does it work? It's based on the model of the snakes and ladder game. You can advance, you can play between 2 and 6 players. And if you come on one of those little scale fields, you can pick up a card. And they were all co-designed with those experts. You will pick up either a barrier or a facilitator. So if you pick up a barrier, which might be you are aged 55 and your GP does not recognize you might have dementia, so young onset dementia, please move 3 steps back. Or it might be a facilitator, for example, you have an unpaid carer who can help you navigate the system, move 2 steps ahead. And we have about 70 or 80 inequalities cards in there. They are slightly different for pre-diagnosis and post-diagnosis. And we also have these question mark fields. So they are about generic questions about dementia. How many people are there? What are the 12 modifiable risk factors for dementia? What are the symptoms of Parkinson's disease dementia, etc. If you hover on the QR code, you should be directed to the Lewy Body Society webpage. And here, just to showcase, we've just completed a student evaluation in our Institute of Population Health, which showed in over 300 students who were playing the game as part of their course modules, it significantly improved knowledge about dementia and about inequalities. So we are now actively working towards widening it out in education, but also in the social care workforce and training, and hopefully in health and social care professionals in practice as well. Because we know that lack of knowledge about dementia is a significant inequality. And I realize I'm coming up to the 10 minutes, so I'm going to skip through my third approach. Apologies for that, but drop me an email if you want to find anything more about it. I just want to finish by highlighting the fact that we've been successfully awarded by the NIHR, the Alzheimer's Society and ESRC, a 5-year national network building on all the work we have done and in collaboration with Newcastle and other universities and non-academic organizations, the Equidem Network Plus. Now we are launching next week, and there will be opportunities for research internships and pilot funding, etc., and to network. So thank you very much. I think that's all I have time for.
Thank you very much, Clarissa. That's great. And I understand that it's all very, very quick and rushed, these sessions, but it's important that people get the gist of what you're talking about. So I just want to leave time for 1 or 2 questions. So Sarah Morris has asked, I'm currently doing my MSc and looking into the equivalence of care between community and prison. Are there any exact figures for people living with dementia in prison? Are you familiar with that information?
Not aware of that, sorry, no.
But obviously a very, very good question, because I'm sure there's a population there as well. Just a comment from Pauline Mountain, just saying that it's really important to raise awareness for all, to include family carers as well. Question here, have you been able to engage with stakeholders who are less digitally literate? E.g., a lot of carers may not be in social media and feel uncomfortable with virtual platforms to share resources and information.
Yes, we do go out. So, for example, Sefton Carer Centre, and in our region, we go out to a lot of those care organisations as well in person. And that's why we host twice a year in-person events, and then we have an annual conference in person as well.
Okay, great. It's also interesting to think about the intersectionality of all this bias. Racial, social and dementia bias may affect individuals at the same time and deeply affect their healthcare journey and outcomes. I think that's absolutely true. I guess one of the things I was going to ask you, you've highlighted the international links across. I just wonder, what work are you doing across the ARCs? Are you doing work across the 15 ARCs, or is it all external international work you're linking in with?
No, it's a mix. And I think with Equidem now, so Equalities in Dementia, that's our acronym, we are working with 4 ARCs, so across the regions as well. And obviously we want to involve more ARCs, and we also work with our DEMCOM fellows, so the Dementia Research Fellows. But yeah, I like, as a German by background, I see the great need to learn more from what the other European countries are doing and trying to share that across as much as we can.
Well, great impact. So I'm afraid we're going to wind up there. We're just a minute or 2 before 2 o'clock, and I know many people will have other meetings going on at 2 o'clock. So I just want to finish today by saying a huge thank you to everyone for 3 excellent presentations. The slides will be shared, the video will be shared. I want to highlight the newsletter. So if you're not got your name down on the newsletter distribution, please do contact us and make sure that you get the updates in the newsletter. This slide illustrates the website for the National ARCs, and our Twitter handle. I'm pleased to see that people have been tweeting as the session's gone on. I'm aware that health inequalities is an area across all the ARCs, and unfortunately, we've only been able to highlight 3 studies today, but there is a lot more work going on across this area and hugely important. I want to just encourage people to pick up the evaluation forms and to fill those in when you receive the request for information to be added to them. Please do, because it helps us make the seminars appropriate for everybody and meets the needs of those that are listening. And I want to highlight the next seminar, which will be held on the 18th of September at 1 o'clock. And that will be on regional health inequalities. That is going to happen on the 18th of September. And a final thank you to all 3 speakers, and also a huge thank you to the comms team who were working behind the chat. To everybody who has made these series of seminars a great success. So just want to say thank you to everybody and have a good day. Finished for your next meetings. Thank you very much to everybody. Bye.